you guys are all, I know you've just started with us, Aubrey, but you guys are generally neurovascular trainees, is that right?
Yep.
Yeah.
Fine, great, okay. Okie dokie. Yeah, so my name's Steve Morgan. We working in Bristol. I'll just get the slideshow up from current. I'm, as you can see, still at work. And Aubrey asked me to chat a bit about ablation mainly. So we'll go into some augmentation, vertebral augmentation, a little bit about implants, ablation. So I don't mind if you want to, I guess, save stuff for the end. We'll try and whiz through. So we're looking at both what we call benign or osteoporotic fractures and pathological fractures. We do quite a bit of ablation. Why do we bother with that? Is a question. Cement, some guidelines, which I'll just brush over, and you can look up if you feel the need. How we do our setup, and then obviously some cases is a bit more interesting for you guys. So. Osteoporotic fractures are extremely common and even more common in our cancer population. That's my main kind of workhorse, are the cancer patients. And clearly pathological fractures can be their first presentation or causes of pain for people with known metastatic disease. In terms of osteoporotic fractures, this is a decent paper if you're going to write it down or look anything up. This is Bill Clark's group in Australia, the VAPOR trials. They looked at mainly, certainly 2/3 were in patients, and one or two fractures, all less than 6 weeks old. So all the old info about vertebroplasties and bad press were generally old fractures, so many months old, and some trials without even an MRI scan. So which is obviously not a patient population we want to do this procedure on, but these are acute fractures. Their pain score was still 7 or greater, and to say 2/3 were inpatients because of that. Primary endpoint of VAS being less than 4 at 14 days or later. So the treatment group was twice as good as the conservative group. Not only that, they saved nearly 6 days of an inpatient stay. So, and as you clearly know and expect to see, most are junctional, and the junction we commonly mean is between T11 and L2. Some evidence also mortality. This is a huge population of nearly 1 million patients in Medicare, 05 to 08, so quite a lowered mortality rate over a 4-year population. There's a smaller group in Germany. I think these are nearly 4,000 patients, but again, quite a significant risk in mortality versus NSM, so non-surgical management over a 5-year period. All these studies show some benefit of kypho over vert. I think that's probably patient selection, whereas I guess the fitter, healthier patients may be offered a balloon as opposed to bleating granny in a bed will just get cement. So I think that's probably the reason for that in the main. Obviously, we see variable presentations, X-ray through A&E. They then get an MRI almost instantly, usually. We see incidental fractures on CT, again on follow-ups. So these aren't to be sniffed at, really. So they're obviously a sign, if they aren't pathological, that people are generally osteoporotic, and then incidental and silent vertebral fractures may well lead suddenly to a fairly grim downhill slide with say, a hip fracture. So it's a way of picking up osteoporotic patients. And even putting granny on opioids isn't great. So then he or she is not able to drive. So they're now dependent and not independent. This is a really complex slide. This is GIRFT, so get it right first time. I'll try and blow a bit of it up for you. So this is the second bit saying patients presented with sudden back pain, over 50, midline tenderness, do an X-ray. Basically, if they still got pain, do an MRI scan, and particularly if they're now an inpatient. So our pain team will have seen them, get an MRI done with a SAG stir usually, and then that's a great rule in and a great rule out. So on the SAG, on the stir sequence, if there's no fracture, obviously they're not going to get offered a vertebroplasty. If they got a fracture, it's acute. We would then tend to try and get to them earlier. Why am I showing you this? Because it's probably coming to most hospitals that can offer this type of service. Depending on your hospital, we will probably have 2 or 3 patients at any one time in the hospital with this kind of reason for admission. So we get several referrals per week, not only from here but from other hospitals nearby, and we already find that a large volume. So it may come to you at some point in time. Osteoporotic fractures in cancer patients is the most common fracture in a cancer patient. It's all their side effects of treatment. They have marked bone and bone year loss. They accelerate their osteoporosis, and this is the highest fracture risk population. So this is mainly what I see. So all cancer patients, but not all pathological in terms of cancer fractures. One quick example: so a normal man would lose 0.5% of bone mineral density per year. You put them on prostate therapy, anti-androgen therapy. They then have accelerated that by tenfold, nearly 5% per year. So no wonder, and that's just one intervention, let alone immobility, general effects of chemotherapy, malnutrition, bed rest, etc. If you can't sleep like Aubrey won't be able to tonight, this is a 1947 paper. The problems of going to bed, and it still holds true. So every body system is affected. 15% of muscle mass per week. So imagine grannies that are in hospital beds for weeks and weeks and weeks. The effect is really substantial. Half of strength within 3 to 5 weeks. 4 months to recover from 10 days of bed rest. So if we can then get these people out and save 6 days, we're hopefully saving them and enabling some people to go home as opposed to going into expensive care homes or with less of a package of care. Non-surgical treatment means conservative therapy, bed rest, bracing. Two terrible things for patients: bed rest and bracing, and carry significant risk. So this is just one example. A 65-year-old guy I saw eventually, I think 3 times. CT left, T2 MRI right. You can see sclerotic Mets, L4 and junctional, but this is his fracture, his L3 fracture. Doesn't look like cancer, just looks like a fracture, which it was. So biopsy negative in terms of cancer. Biparticular approach at this time, we're going to probably see some cement go through his fracture line. We use curved needles, so they're pretty cool and pretty easy to use. So we can get across the midline with a curved needle if we need to. Some cement, a little bit through his fracture cleft. Who cares? I think that's probably a good thing. And he did well, so home. And as I say, he's able to continue mobilizing. So nothing really directly to do with cancer, but it made him worse, if you like, more immobile, and pain is obviously a major player. So then cancer patients with known Mets, or this may be first presentation, biopsy is obviously key, and pre-radiotherapy is obviously key, or we ask them where they've had to do radiotherapy, for example, for impending MSCC, and we'll pick a different site. Radiotherapy itself is a risk factor. It does take some time to respond to radiotherapy, and obviously there are lots of tissue groups that are not sensitive. This is from a surgical paper, 97. Biology remains king. Like everything we do, selection of patients / cases is next important. Then what else we do is just trying to interact with those two critical things. So it's a decent quote from back in 97. So in terms of particularly bone and particularly spine, their fractures will be the presenting complaint in 1 in 5. The usual gamut of presenting features. We see lots of hematogenous stuff, myeloma in particular, because it's very lytic. Radiosensitivity, so the most common tumors we see in the Western world, breast and prostate, are relatively intermediate. These are our 2 big players. We're quite a big urological centre. We see lots of RCCs, again, which are not sensitive. Sarcoma is a terrible group of diseases, which is very difficult to treat. And on the flip side, lots of things are sensitive. So particularly the hematogenous and small cell lungs do well. So overall, 2/3 respond to external beam radiotherapy. I think it's a great thing. Cheap initial treatment, £400-500 for a series, usually over 5 or 6 fractions, but it does leave quite a proportion that don't get any response, or certainly don't get complete pain response. There's about a 5% risk of fracture with external beam radiotherapy due to bone loss. And as the previous slide said, some are resistant. And sometimes with the hematogenous ones, they don't want to give radiotherapy because they're going to have a bone marrow transplant, which entails whole body radiation. So they'd rather not use radiation across the cord if they can. and lots of people have already had radiation for different things. And just to highlight, it does take sometimes up to 6 weeks, which is a long time if you're dying in pain. 6 weeks is a long time to wait. Stereotactic you'll know about for intracranial stuff. It's a similar thing, a bit like a gamma knife. It's sometimes called cyber knife. More peripherally, so it's stereotactic radiotherapy, and hence the dose can go up. So the response rate goes up, but the fracture rate also goes up to about 14% from 5%. Radiation myelitis remains low because it's fairly, you can plan it quite carefully. Unlike everything we do, the local failure rate is bad because it's posterior. So can we predict? So we're getting to the stage where the oncologists now are forwarding us patients pre-SBRT saying, do we need to avert this first? So this is a nice paper showing 4 key variables. So epidural disease, lumbar location, large tumor, and a SIN score of more than 6 is, so if we look at those variables, if you have 1, the risk of fracture is low, but look at 4, so it goes from a 6% fracture rate to nearly 36%. So we would just score them quite quickly and easily and say, look, if it's 3 to 4, we probably should intervene pre. If not, don't bother unless they've got a lot of pain. So that's pretty useful, and that is Kowalchuk 22, so quite a useful paper. I can send you the slides, or I think we're going to record this anyway, so Aubrey can send you the links if you need them. We don't just cement tumours because they're quite different pathologies, which used to be the case, and that probably is still the case in some places. Mets, as you'll know, tend to be lytic. They tend to be multiple. They tend to be posterior, which is the worst place for them. Usually a venous route of spread in terms of hematogenous spread. So this is pictures before and after a balloon kyphoplasty showing kind of direct mechanical tumor spread. So T9 pathological fracture, balloon kyphoplasty this time. So literally pushing tumor sideways and replacing tumor with cement. So seemingly a good idea at the time. Pain was better, but only 4 weeks later, you've got T8, T9, T10 disease, anterior, posterior. So mechanical spread of tumor. Look at the axial before and after. So not really much of a success. This is slightly different in terms of probably just hematogenous seeding. T9 clear, this is a melanoma. T9 clear before and involved, again, a short 4-week interval. So treated T10 here, again, with a balloon, and the black line here is cement. We've got epidural disease, we've got lots of T9 disease and worsening disease at T10. So mechanical and hematogenous spread of tumor, which we're trying to avoid. This is the old, or still the current way of treating, and quite reasonably in terms of an osteoporotic fracture, which fractures anteriorly. So you want to support the anterior 2/3, which still remains reasonable. Unfortunately, we know most of our tumors are posteriorly based. So at 5 months, the fractures are okay still, but we've got posterior. We haven't done anything for tumor, basically. We've got posterior epidural disease. So with METs, like we've done 3 cases today, we ablate prior to cement when we can. When I don't would be a big sclerotic lesion, so you can't get cement in there safely. It's like trying to inject cement into a table. It's impossible. So that we there's some evidence now, at least, we create a cavity for tumor, for cement and less leak. Certainly some cell death over 60 degrees, lowering extravasation, lowering the systemic spread of tumor cells. I'll show you a paper where we think it's synergistic with radiotherapy. You'll have heard probably about BVN ablation, so we always target the center of the vertebral body and annihilate those fibers as well, and help local control of tumor. So we're controlling pain, some stabilization, and aiming for tumor control, preventing the worst outcome in terms of cord compression. This just shows an example of any type of thermal ablation helps bone mets. So this isn't just RF, which we use in spine, but cryo, RF, MR guided ultrasound. We've got microwave in there from Major and Kastler's group. So this is general bone mets. So all of these things to help pain from bone mets. So thermal ablation works for bone pain essentially. Now, in terms of skeletal mets, we've just, in terms of RF, which is probably the safest, most combined with cement, they're just case series. So we won't get, when we talk to oncologists, we don't get randomized control trials. They're a very select palliative group of patients, so they're just case series. But we do see a good reduction in pain, A mean 4 to 6 point drop on a 10-point scale is big. Lots show a good reduction in analgesic requirements, but we maintain we don't have RCTs. But I think the results are good, and they remain in our data is similar to this. Considering everyone's been through every other treatment option, they usually come to us with no other option. So lots of people respond, which is good. This small group again in 2011 compared RT against ablation and RT, so 15 against 30, and it showed from our initial 60% response, which is reasonable, a big jump. Half now get complete pain relief, and also time to pain relief drops as well. So more respond and respond more quickly, which is good. Can we see local control? This is again Jack Jennings' group in St. Louis. These are renal mets. He has treated, if you look at L2 and L3 here, they've now been cemented and ablated. They're stable. A few months later, the ones above they haven't treated have progressed. They've gone back in and treated T11 and T12. And again, this is a 3-month follow-up, cement and ablation. And the renal ones do relatively well with a decent amount of heat. And we'll leave them mobile. Generally, pain is less, and they'll generally then succumb for some other reason further down the line. This one just looks at cement leaks. So again, ablation and vertebroplasty in tumors against just cement. So overall cement leak is much less, venous is less, and the posterior is less, but no change in, they saw no change in leak through into the discs, i.e. fracture clefts. So this is tending to support, we've got less venous leak as opposed to fracture leak through clefts. So clefts didn't change with RF. Venous, i.e. hematogenous leaks, were significantly less. This is Jack's group again. This is St. Louis looking at patients in terms of local control. They looked at their database. They excluded cases who've had radiotherapy and ended up with 55, and they showed a local control rate of 70%, so 2 out of 3 at 1 year. So and none had gone into cord compression, which is pretty impressive because again they're end of line and they've excluded radiotherapy. So that's a high number, but that looks good and looks promising. More recent paper. This is Live, not the golf network, but Nanning Live. Again, looking at RF and cement against Group B, which is cement, so slightly bigger numbers, 47 mets against 78. Leak rates are lower, and at 6 months, pain is lower and recurrence is lower. So kind of a bigger number and 3 good outcomes in terms of leak, pain, and recurrence. So 3 times less recurrence, significant differences in the simple pain score and Osgood Disability Index and leaks. I'll just flip through guidelines in case you're interested. We have NICE guidance, NCCN, National Cancer Network, US, you can look up. Oncology Working Group is a bit old now, and the IMWG is the Myeloma Working Group. So there are numbers of guidelines. We helped NICE develop this last year. So 5th of April, there are 2 guidelines, one for RF with cement essentially, and one for RF on its own. So go ahead, read that. That was published in April. NCCN, the latest update, I think 2019 now. Oncology Working Group's kind of 10 years old, but it's there. And the Myeloma Working Group is from 2019. So feel free to look those up. We, in terms of our setup, we see a lot through, obviously you might expect different MDTs, oncology networks. We have a weekly complex spine MDT, and also through our radiology kind of governance meetings, sometimes, and colleagues just ask me what I think about this one. That's come from a different MDT. We run a monthly palliative care pain MDT, which is really useful and beneficial. So we run through imaging, and myself and a pain consultant can advise on different things, not just cement, but different types of blocks and interventions. Unknown primary MDT, clearly they need tissue biopsy more than other people do. If it's painful and fractured at the same time, we'll ablate and cement. And now they're requesting that in addition to their biopsy. We've got very good acute oncology and acute pain nurses within our hospital, so they often just approach us directly by email. SIN score, unless you must have heard of that by now. So it's initially made up in 2010 by a group of surgeons because they were getting so many inappropriate referrals from different medics about cord compression. So they brought this scale. It's 6 simple categories. Only one the clinician has to input in terms of pain, and gives you an idea of stability. And generally the 3 is 0 to 6, 6 to 12, 12 to 18. So it's fairly inter-reader reliable and cuts down on unnecessary referrals. We are still seeing, in terms of our treatment group, seeing people too late, really. So early the better from oncology. Pain is obviously a driver, and like today, we've done one asymptomatic lady because we just picked up a met on a whole spine MR. So we'll do lots of these things, and sometimes preventative if they haven't fractured yet. Our spine MDT has the usual gamut of attendees. We have also our neurospine, nurse specialists, trainees, physios, our colleagues and our fellows. We discuss all cases either in the MDT or with the on-call surgeon if it needs to happen before the next MDT. Monthly pain MDT in terms of palliative care, so it's useful. We see people preoperatively. We do have an option now of general anaesthetic, which is useful if they can get into their pre-op slots. We have an animation people can watch if they're in a different hospital. Probably 2/3 under conscious sedation and 1/3 GA. I'll probably try and up the GA when we get more funding because it's much easier. They can go ahead and have radiation therapy the next day. They can usually carry on their chemotherapy unless they're neutropenic. We give them a little week or 2 window, and we have backup on site, which we've not had to use. Just an example of a referral. Please, can you have a look at this one? Breast T8. So let's go. Had some radiotherapy. I don't think there was another site, so we had to go to T8 and try, and she was getting pain. We have CTMR, we do our SINs, then we're trying to plan it, see if it's appropriate, look at our bloods. We have a pro forma I can send you if you're interested. And then we would go through a surgeon or the MDT. As I say, that's just our local pro forma, which we're amending because it's still getting inappropriate referrals. So maybe I'll send you the amended version if you're interested. The radiotherapy scan's quite useful in addition to obviously knowing where they've had it and when. MR spine clearly useful and their last staging. No prizes for guessing. T8 is this one here, collapse, some epidural disease. So we're automatically going to be a bit careful because she's already it's already convex posteriorly, so we want to be a bit careful there. We're going to have a look at her pedicles. I'm just showing you our scanograms because it counts T8 from both C2 and L5. So I don't think we get confused with this one because it's the only fractured level. But sometimes if something hasn't fractured, you ought to be a bit careful with your count. Axial automatically, we've got tumoral expansion of a right pedicle, so makes this is the obvious entry point as opposed to a normal, very thin left pedicle. So automatically now I'm going to go right-sided. We've got some epidural disease, so it's just encroaching. We're looking at one in terms of epidural score there, maybe 1B, just touching the front of the thecal sac there and just some indentation, so low grade still. Bit higher grade there, so it's pressing now on the cord, so that's getting into grade 2. Still a little bit of CSF, so yeah, tissue. We need MR and CT, 1 to do the SIN score and 2 to see how lytic or sclerotic it is. It's going to be breast. It's going to be quite miserable because it's going to be lytic and sclerotic, so it can be really difficult. Expanded tumoral pedicles, that's clearly our route in. Getting the right plane on our 3D recons, you can see most of it's just lytic. So how are we going to plan this? Check their chemo, check their bloods. Any blood thinners, we've been caught out with people on lots of chemo. Agents get put on their oral anticoagulation drugs because the chemo is reasonably pro-coagulant. So we've been caught out a couple of times in our early days, so check on that. Allergy is obviously important. They come in with a relative usually because they can be quite knocked off and quite not forgetful, but stressed, I guess. And it's always useful to have a relative with them. Again, they can see an animation. I can send you the link for the animation if you want to see that. And then through the MDT. Blood's mainly looking at HB, I guess, platelets generally above 70, neutrophils generally above 1, although everyone gets antibiotics. So if they do dip during their chemo cycle, we'll delay a cycle by maybe a couple of weeks. And that's just on, neutral. She doesn't dip. We're going to choose which kind. So multiple different systems on the market. We currently have electrodes that are 2 or 3 centimeters long, just for ease and convenience. So you could do whatever you like here. Probably a 2. Generally, thoracic is the smaller, and bigger chaps particularly will tolerate a 3 centimeter in the lumbar area. I think I've got here we go. This might work. Let's just see if this will play. If I go back again. Here we go. Right, you might hear me talking over this as well. So current probe, we're heating up 26, 27 watts is quite a bit, and we've seen that even today. So certain systems are of lower power. We've got 2 thermocouples on this electrode, so they're both at the same point and generally recording the same temperature. I'm going to move the second thermocouple back along the probe here. So I pulled it back a centimeter and it's gone. So the edge of the ablation zone, particularly the RF, is quite narrow, which is a good thing. So if we're nearer the cord, we know what the temperature is there. We have got also an external thermocouple, this yellow temperature here. So I'm just playing around with the moving thermocouple, and then I'm going to put in, you watch this, here we go, an external thermocouple coming in to the center of the ablation zone. You see it's much hotter, so this 60 degrees is measuring the very periphery of the ablation zone. And even at 60 degrees, which is generally instant cell death, the center of the ablation zone gets up to 80, 90 degrees. So we're cooking kind of an ovoid rugby ball shape, if you like. So I think that's probably all I need to show you on the video. Let's move on. So for that patient, we're definitely going to start on the right. We could go on the left if we're really feeling confident after that. We generally use a 2 centimeter burn zone. Balloons we don't really use much of anymore. It just goes in and out of fashion, I guess. And we would be quite cautious with cement. You've all got fancy biplane labs, same as we do. So I can't really show off to you guys with this. Really, you've got the same, haven't you? So. Next case is hematogenous. Mainly this one is for tissue biopsy and typing, and then chemo protocoling. So both bone and soft tissue biopsies. You can see they haven't got a pedicle, so it's a missing pedicle. So we use the one above and below as a guide. In this case, you can see no posterior cortex again because it's just tumor. This is a merit system, so we got across the midline this time, cooking that one. That's a standard Temno soft tissue biopsy. We've been again cautious, filling with cement. Mainly biopsy secondary to this then is just the cement and the ablation just to hold it in line while the systemic takes effect. So look at the differences. Once they know what it is, the chemotherapy agents can be quite clever and do their work. So fairly stable, hasn't collapsed hideously, and we've at least typed tissue for them so they can get their wonderful systemic drugs into the patient. So we've at least helped them with that one, and the patient did well. Our caseload is relatively static the last 3 or 4 years. Again, we've just completed 2013 kind of audit where I think it was 39 tumors and maybe 20 osteoporotic. So we're probably now nearing 300 in terms of total and 300 tumors. Usual mix. Hematogenous stuff is mainly myeloma, to be fair, breast, prostate, lung, unknown primary. So renal, usual customers. Our 2018, 19, 21, 2 and 3 outcomes are similar. So pain score is generally 8, goes down to about a 4. Their overall health score improves afterwards. So they give me a score from 0 being terrible, put me in a box, to 100 being perfect. So their perceived overall health score improves after treatment as well. So that's nice. And we do see cement leaks, and again holds firm. We quote them 50% for a tumor, which is usually a small segmental vein, about 30% for benigns. Most are day cases. Some already are current inpatients, and very occasionally they need to stay in overnight for other reasons, for other medications, and being watched and not safe to go home for other reasons. And again, we don't see many adjacent level fractures. So even on a very osteoporotic group, the misnomer that cement causes adjacent level collapse is just entire rubbish. This is a fairly complex T8. So you can see they've been fixed further down. You can see the artifact on the MR. T8's fractured and causing them some irritation and trouble. So it can get a little bit complicated on table. So it's like you guys, when you're doing more complex stuff, 2 pairs of eyes are helpful. We use curved needles. They've got ablation wise, they've got a sternotomy, their fixation is lower down, they've got an esophageal probe, and then we've cemented under GA. We've done 5 levels for this lady, and she did well. You'll know this more than me, so we've had embo coils, particularly for the hypervascular tumors, so notably renals. Really, you don't see many thyroids. We've had coils been called cement extravasation 2 or 3 times on different scans. We've had to go back and educate people what platinum looks like in terms of the artifact, and it's different to cement. Aubrey's going to start doing our embolizations for us. That'll be really kind, like his colleagues have done. So real large tumoral blush, some coils in there, and we now do that under the same GA. So supine first, obviously to have femoral access generally, and then we flip them prone to do the spine procedure under the same GA, and they generally stay in because it's a long GA. We don't always cement, so this was, we thought probably a myeloma, and they were getting neurology already. So the main thing here was biopsy. So the decision was reasonable. So look, they got fair neurology already, so let's just get a biopsy and see what it is. And it was, and very occasionally do see them start to recorticate. So this was myeloma. So after treatment, systemically and radiotherapy, they can just start to recorticate. That's I think limited to certain myelomas. And again, they've done well with their systemic therapy. So we did a biopsy. We just did, I think, a simple track ablation. You can still see the track here, and then let systemics take over. Obviously, very sclerotic things like this L4 PET positive lesion in the pedicle. Again, biopsy and ablate. Don't bother trying to cement these. As I said earlier, it's going to be really difficult. You're going to have a big complication rate. And she's done well, so still PET negative. We're starting to use implants. If I just go through, another 2 or 3 minutes. We have used a couple of things. So spine jack we're starting to use. This was a real presentation with back pain. Weight loss 73. He has lung mets, liver mets. His colonic primary is here. And in terms of his spine, it's this met in L2, so a decent, easy place to biopsy. He was a friend of our chief executive, moribund, basically in bed, 9 out of 10 pain. Not surprisingly, left radicular pain at L2 with a degree of collapse. His scores were terrible, so these are scores. The max you can score is 5, so mobility terrible, washing and dressing terrible. Are you doing any usual activities? None. Pain, 10 or 9 out of 10, and anxiety or depression, at least a 3, so moderate. His global health score is down to 10, so nearly shoot me in the head level from previously, only a couple of weeks earlier, playing golf. So he was a highly functioning guy. He required an ambulance and 4-man, prone stretcher even to bring him in for a CT scan. He scored 9 on the SIN score, so that's my kind of domain between 6 and 12, I guess. So it's not acute, needing decompression instantly. So that's our kind of middle ground that we usually see. Same sort of planning. He progressed a bit, so even in 3 weeks from the CT looks quite inviting. MR now, he's collapsed quite a bit, more epidural component given the collapse. But we thought we'd try, and if we could stabilize him or jack him up slightly, we'd give it a go. Lytic pedicle, use the one above and below as your medial guide and safety line. We go in with our normal 11 gauge cannulas first, give him some ablation. That's our ablation probe. We're ablating back into his pedicle here. If you can see the MRI, there was a little bit of tumor in L3 as well. So hence we're putting a second needle while we're cooking into L3. I'm going to cement the back of L3 post-ablating the front. Back to L2 afterwards. We then exchange our 11 gauge needles over K-wise for the 8 gauge. You can see the size of the spine jack. Introduce a needle, hence a GA. Sizing the spine jack, 3 different sizes. Mainly we're using mediums and large. This was a medium size. Size them both up and jack them both up. Nothing too complicated, but we got some height, some stability, and then we can cement through the middle. So those are the two in place. We can cement through, looks a bit better, and he's not actually moving, so his pain was significantly better. People are often more functionally better than the images look, so not too disappointed with those images, to be honest. So from in bed, he was in 6 days later. I think we did the procedure on the 10th of March. He's walking unaided, gone home, no back pain, scores are better, he's better. And then he's got a performance status much like a normal person, and oncology are more inclined to give him chemotherapy. If someone's lying in bed, the performance status is terrible, they won't even get any, not even palliative chemotherapy. So it's important for us to remove people from hospital beds. A cheaper option, and for different things really, is the vertebral body stent, J&J. Again, quite useful. We use it for kind of lytic cavities. I think it's only 400 quid as opposed to a couple of £1,000 for us for the spine jacks, so that they are much cheaper. And this is just an example of one going in again from this is May last year. So a balloon in the middle of it, blowing it up, and then we take the balloon out essentially, and it's got a radial force, much like a stent of any other kind, and you can cement quite safely through it. So that's the result there, and they did well. And if you're interested, look up Alessandro Cianfoni. He's Italian but living in Switzerland. So look at the safe technique. So he does even further than this, and he puts pedicle screws in as well, which I think is pretty cool. So if he's got an intact pedicle, he'll do this, put a screw in, and then you can cement through the cannulated screw. Pretty cool. So in summary, I think I've just finished in time. We use it as a team. There's so many patients. We're not drowning yet, but getting close. Painful fractures, obviously. Biopsies we do lots of. Junctional worsening pain, yes, we treat those obviously, and in combination with other things. So I think that's it. So feel free. Sorry, it was a bit of a rush through, but there was quite a bit to get through.
No, that's great, Steve. Thank you very much for that talk.
It's okay.
Stephen, does anybody have any questions at all?
They're probably all asleep.
No. Hi, Taimur. Did you have a question?
No, I was just saying none from me. Thank you.
Okay, cool. So that's great. I mean, Steve, the results from those are fantastic. And from all the cases that you've shown and everything. Have you found now that with all the RFA and all the oncology, your referrals, have they significantly increased now that all that treatment is available and all that evidence? How's that affected your service in terms of numbers and
yeah,
like
it waxes and wanes a bit, but yeah, it's busier. So today's a Thursday, so Richard James we're in Bristol, right? So Richard comes over from Bath, so brings a cohort of patients from Bath as well, because they don't have the facilities there. So we're already 2 centres, if you like, combined. We still, I think we're getting a little bit more selective. I think when you initially start off, you just want to treat everything. Then you realize what should and shouldn't be treated, or what's within your remit. So for example, multi-level rheumatoid fractures I know are a complete disaster, and patients are really crumbly. So that's generally a group we'll try and avoid. Likewise, really extensive cancer, we need to be pushed into really. So yes, referrals go up, but I think we've become slightly more selective. We know which cases respond better to the RF. We're looking at other therapies all the time. So I think we were briefly touched on, we're not really good at treating any epidural disease yet, because we can't really cook that close to the thecal sac and get posteriorly well enough. So we've got a new technique coming online next month, hopefully, called ECT. So that may help the next group of posterior epidural disease cohort. So that'll probably increase our numbers further. But yeah, I guess we are doing a fair amount. But like today, we can easily do 3 or 4 cases in a day. And we're moving to 2 days a week. So yes, in a nutshell, yes, getting busier, but we are slightly more selective as well.
Yeah, And I mean, I know a lot of these guys will be doing neurovascular, but it's a nice thing to do on top of the neurovascular work. It's a really rewarding thing to do.
Yeah.
So if you're interested, do get in touch if you're not doing it locally, and let us know what you think.
Yeah, Aubrey's got my email. You can send on the references, whatever you like, really. Just
Perfect.
Get in touch.
But thanks very much, Steve. Thank you very much for your time after your busy day as well. And thanks very much for everybody joining. And the next teaching session is going to be on the 14th of August, and it's with Dr. Willie Butt. He's going to be discussing embolization of retinoblastoma. So, okay, thanks very much, everybody. Thank you, Steve, again.
Cheers, guys. See
you
you later.
Thanks.
Thanks.
Thank
Bye.
you.
Cheers. Bye.